Hello, in this presentation, I will discuss the current state of pharmacogenomic knowledge related to letrozole and aromatase. This discussion is in the context of breast cancers that overexpress estrogen receptors. This includes nearly 70% of all breast cancers. The treatment involves either inhibition of the estrogen receptors by using selective ER modulators such as tamoxifen, or suppression of estrogen by inhibiting aromatase, the enzyme involved in its synthesis. Although SERMs such as tamoxifen have been the standard therapy for ER-positive breast cancer, for postmenopausal women, the new generation of AIs are recognized to have a better safety profile. Letrozole is a non-steroidal AI. AIs have a high specificity for aromatase and they cause nearly complete suppression of estrogen. In recent clinical trials, AIs have led to better outcomes compared to tamoxifen. Letrozole may be used for ER-positive early breast cancer treatment in an adjuvant setting, for extension of adjuvant therapy, and also as a first and second line of treatment of breast cancer in which the ER status is positive or unknown. Androstenedione and testosterone are converted into estrone and estradiol by aromatase. As we can see in the pathway sketch, by inhibiting aromatase, we can effectively reduce the production of estrogen. Side effects of letrozole are mainly related to the effects of hypoestrogenism and include musculoskeletal symptoms, with long-term usage leading to osteoporosis. Aromatase is located on the long arm of chromosome 15. It has 9 coding exons and several alternatives for one non-coding exon, which is understood to direct expression in a tissue-specific manner. In a sequencing study of aromatase that included resequencing of all coding exons and splice sites, 88 polymorphisms were observed. The number and type of polymorphisms also varied across the 4 ethnic groups from which the DNA samples were taken. Out of these polymorphisms, 4 were non-synonymous variations and 2 out of these 4 were novel. 2 variations were observed only in the Han Chinese subgroup. The enzyme activity of alleles with the threonine 364 variation and the cysteine 264 arginine 39 double variation was significantly reduced compared to the wild type allele. Also, a positive correlation between enzyme activity and the protein quantity was observed. In a study of the possible association of the SNPs and aromatase with letrozole efficacy, RS4646 was found to be associated with a significant improvement in time to progression. CYP2A6 metabolizes letrozole into an inactive metabolite. Plasma concentrations of letrozole and consequently the exposure to letrozole have also been found to vary by as much as 30% depending on which polymorphisms of CYP2A6 are present. Since letrozole efficacy will depend on its plasma concentration as well as on aromatase activity, a better understanding of the pharmacogenomics could help us determine which patients stand to benefit the most, what is the right dose for a patient, and can concomitant medication cause adverse events. However, before we can translate these early insights into patient care, more work needs to be done. We need a deeper understanding of letrozole metabolism and the genes involved in the various metabolic pathways. We also need to identify and annotate with a high degree of repeatability the polymorphisms associated with letrozole efficacy and toxicity.